and I'll start as soon as my slides are ready. So I am arguing the opposite point, which is that renal denervation is the most significant step backwards in the management of resistant hypertension, in the sense of loss of IQ or intellectual power amongst the clinicians using it. And it should be used in the NHS, certainly, but only once we regain our senses. And I'll explain what I mean. So I do have some disclosures. I am actually, until today, a consultant to Medtronic regarding renal denervation. Don't worry, I kept the bus ticket, so I'll be all right. We are a species of optimists. Our entire evolution has arisen through taking on challenges and embarking on major projects with very little information or confidence on where they may lead. We have optimism that we can overcome every hurdle. This little guy, if he wasn't an optimist, we would still be in the primordial soup. We'd just be amoeba. And Dr. de Belder, as an interventional cardiologist, is the intellectual child of one of the world's greatest optimists, Werner Forssmann, who asked permission from his hospital to do a cardiac catheter on himself. They thought about it and they said no. So he tricked a staff sister in the hospital into anesthetizing his arm and then tied her to the bed so that he could do a catheter on himself and she couldn't raise the alarm. He was an optimist. But now let's have a quiz for non-invasive cardiologists and hypertension specialists. So suppose you see a 76-year-old man who has a blood pressure of 166 by 78 2 weeks ago. You started him on amlodipine 10 milligrams OD, and now his blood pressure is 168 by 79. It's gone up a little bit. This ever happened to you? Yeah, see a few nods. So I give you a multiple choice. You have the following choices, which will come up once the laser guided. Okay, good. 1, document reverse response. 2, document intolerance. 3, review in 2 weeks. And 4, measure the blood pressure again. So who would go for A, document reverse response? Go on. Mel Lobo? No? Okay. Intolerance? Intolerance? Review in 2 weeks? Who's in private practice? Ah, very good. And so the rest of you would press the button again, yes? Yeah, and that's the correct answer. If you don't, you're an idiot. And that is the correct answer. Because how are you going to write a letter to the GP? It just looks stupid, doesn't it? I've done this, and it's gone backwards. And when you do it, the blood pressure is indeed 154/69. Everyone's happy. It has gone down a little bit. And is that actually wrong? Is that illegal against the rules? If you read the small print on how to do blood pressure, where does it say you must not cheat? His brother comes in. He also had blood pressure of 166, but he said, I'm really sorry, doctor, I never made it to the pharmacy. I never took them tablets. And his blood pressure is 168 by 79. Of course it is. What do you expect? What do you expect? And that's the real problem we face when cardiologists do things that are very specialized, like measuring blood pressure, which should be left to people who know how to do it. Because in cardiology, all the time, we use our common sense. Oxygen saturation is 73%. How are you doing, Mrs. Jones? I feel absolutely fine. Why do you ask? Well, let me just have a little fiddle with this thingamajig here. 99, that's much better. Right, good. Everyone happy? But what are you going to write down? 73%, because you've got to take your first answer. Is it like mastermind? 73 and 99, are we obsessive, like Peter Sever? Or like our research nurse, Francis Stewart, who suggested this, 73 plus 99 divided by 2 is 86. I have an MSc, why shouldn't I do that? Or like normal people, will you just cheat and write the number that fits the clinical picture? So this is the background I'd like to set for you on the renal denervation discrepancy, the office blood pressure being on average 30 drop, and the ambulatory blood pressure drop being 10. This is a 3-to-1 discrepancy. Nothing like this has ever been seen before in the non-fiction section. of Google. Because this is what we're being asked to believe. Here is an ambulatory blood pressure showing systolic and diastolic. And of course, we know that in every time that anyone has tested it, almost always, except for some examples which I will show you, that blood pressure drops by 10 millimeters of mercury on the ambulatory trace, like so. Agreed? That is what we see on the ambulatory trace. I see some people looking worried and saying that can't be right, because in fact, while they're in the office, and they stay in our office for a long time as they shamble from one building to another, getting lost and getting their prescriptions, their blood pressure is actually 30 millimeters lower. It's a major dent in their ABPM trace. I see Frances shaking her head sadly with her mathematical bent. That's not right, because if you're 30 millimeters lower for a few hours, you can't then be 10 millimeters lower for the rest of the day. It doesn't add up. That's too much drop. So if you're 30 millimeters lower for a few hours, you need to be 0 lower for the rest of the day. So this is a therapy that only works when the patient is in the hospital, because that is enough to explain the 30 millimeter drop in clinic and 10 millimeter drop 24 hours wise, which means 0 when they're not in the clinic. This is bizarre. Because if that is not the case, then the office blood pressure drops must be exaggerated. And this can only be explained by an overestimation of the baseline pressure or an underestimation of the final pressure. How could this happen? Now, we have another disclosure. Mark and I do have another little private company which I haven't talked to people about. And despite being hard-hitting cardiologists, we are interested in the natural approach. Some of you recognize this, Evening Primrose. And as you know, it's available in tablet form from us at a cheap price, where it is known to cure cancer, improve the complexion, and reduce blood pressure. Now, the difficulty for us is it involves tablets, which we don't like, do we, Mark? We like a permanent solution. So Mark has devised the primulation catheter. There it is, ladies and gentlemen. Now, it's quite complex, but it comes in a very convenient set like this. And what you do is this catheter is maneuverable to point in any direction. And he's worked out that you can go on the body and find the place that is least well studied. All the nerves on the body are well studied except in one place. Can you see it? Yes. Nobody looks there. Just like the renal nerves, it's a heavily overlooked area. So we've set up a course, obviously in Frankfurt, where all the new innovations come from. And this is how Mark recommends we do it. Bring the catheter in here, rotate it into place, and if you squirt it just right, you get this effect. If you overdo it, you get this, and that's no good. And let's see how Mark recruited for this study. So the study is obviously called Complexity 1, and it's the world's first evening primrose oil scalp application system for resistant hypertension. Now, some of you think it doesn't work, but we had really good results. It was a first-in-man study, so we didn't have to have controls. And the entrance criteria was an office blood pressure over 160. So here is Bob. He has resistant hypertension with lots of drugs. Some days his BP is controlled, and other days it isn't. It averages 150. He often forgets his tablets, but he always remembers to go and see Dr. Mark. On the first day he visits him, he was having an average day. Blood pressure was 150, so sadly he was not eligible for the primulation trial. On the second day, he actually remembered more of his tablets than usual, and he was still not eligible. Blood pressure was 140. On the third day, the blood pressure was 170, because he was very stressed and missed some of his tablets for a few days. He was enrolled, and that pressure was written down as the baseline office, and ambulatory pressure was also recorded. So Bob undergoes his primulation as part of Complexity 1, and his blood pressure falls to, on average, 150. It's an ineffective therapy, I can tell you, off the record, don't tell anyone. Unfortunately, his ambulatory blood pressure showed no difference at all. But Complexity 1 was a major success because the primary endpoint was office blood pressure. So we got it into the Lancet, as usual. And this showed an amazing expanding effect with time. Now, people criticized us in Complexity. They said it was just office blood pressure. But I said we had a special protocol. We had a protocol that we printed out every every first 3 measurements and stapled it into the CRF. People said, did you have a protocol for capturing the printouts that went in the bin? And I said, this is shocking. This is outrageous that they could ever say that Mark and I could ever cheat, except in looking at post-angioplasty visual stenosis. Sometimes we sort of bend that bit, but that's all right. That's not really cheating. So I decided we should try and make some money from this. So we actually developed a way of capturing the offcuts from a pressure monitor when you in the clinic. It would pick up all the little strips, and we filed a patent. It's quite a complicated patent, but I can show it to you now. And it goes, it needs to go under the clinic, and it has lots of components. But we filed it. Mark, I've got really bad news. I just heard this morning, I had an email from the patent office. It's got rejected. What they say is, doctors, your method you've devised for capturing discarded values that have been omitted from clinical trials is very, very useful and very, very excellent. Unfortunately, it's been invented already. It's called the ambulatory blood pressure monitor. So, a bit disappointing, but these things happen. Success bred success. So the Complexity 1 trial moved on to Complexity 2 that did have control. And Bob was so pleased that he invited his twin brothers. Their office blood pressures averaged 170, and they both wanted primulation. But unfortunately, Ben was randomized to optimal medical therapy. So Bill had primulation, baseline blood pressure 170. He had primulation. Next office was 175. What would you do? No, don't answer that. You've already told me what you would do. You all told me what you would do. You would remeasure. And his next pressure was 165, very effective. Ben, his twin brother, was feeling miserable. Blood pressure was 175, and you put him out of his misery. You just wrote that down and let him out of the clinic because you know you've told me that you'd do that. So here was a Complexity 2 mystery result. Excellent office effect of 20 millimeters of mercury. No effect on ABPM. The usual suspect experts, Mel Lobo et al., were invited to give panel discussions, and they were wheeled out in their wheelchairs and gave a brilliant explanation. They said, this is a little understood part of the nervous system. This is a particular effect on the white coat response. And people do not realize the entire white coat response passes through this point on the scalp, just where the primulation catheter is applied. And that is the explanation. Amazingly enough, people believed it, and there was all kinds of documents showing it, and people said this always happens. So people say that in drug trials this happens as well. And this is something that is going to be taken up by one of the young investigators later, but effect size actually matters. It matters a lot because you can have soft endpoint studies. Those are ones that are easily manipulated, especially by staff who are highly experienced in doing so, as you've just told me you are. Or hard endpoint studies, which are events. And the trouble with these is they need very large numbers of patients. And there's a reason there are thousands and thousands of patients there, which is when you design an event trial, the sample size you need is proportional to the event rate divided by the absolute reduction in event rate squared. Which is the most important part of this formula? The 2. That is the most important part of the formula. So suppose you design an endpoint trial and you have overestimated the effect size on blood pressure. In reality, it is 2-fold smaller. It's n-fold smaller. You'll need n squared more patients to prove the point on events. So if you have a 2-fold smaller effect, anyone here from St. Jude? Good, excellent, right. How many more patients would you need if you had a 2-fold smaller? 2 squared, so it's 4. Yeah. So on this calculation, it's 4. 4-fold more patients needed. But what have we got in denervation? You've got inflated, pick your own values like strawberries, and scientifically documented values. And they are 30 millimeters and 10 millimeters. That is a 3-fold overestimation. So if we use the results of the major trials to plan our endpoint studies, which is what the NHS might be interested in seeing, then this is what will happen. A 3-fold smaller effect. How many more patients? 9. We need 9 times more patients than we think we needed. And the result of that, with endpoint trials that are underpowered by almost 10-fold, is an overestimated effect size and misery, because you think it doesn't work on endpoints. So it's very important that we have bias-resistant measurements, and the way to do that is to have denervation and a sham procedure, and then to measure ABPM blinded in both arms to be completely sure to minimize the bias. Because I'd like to ask you, if I've got a few more seconds, to ask you to help me with the white coat conundrum. Now, my cardiologist colleagues find this all too difficult and mathematical, but I thought you might be able to advise me. So if you have, that is your baseline office pressure, and it falls to that level, like so, and here is your ambulatory pressure, and it obviously is lower, and it starts here, and falls like so. They have both fallen by the same amount. Yes? Agreed? I've drawn it that way. So whatever the white coat effect, now I know some people say that's not the white coat effect, there's other definitions, but let's for simplicity call this a white coat effect. Whatever it is at baseline, that's what it is at the end. But suppose you have what we really have in renal denervation, which is a massive drop in office pressure and only a small drop in ambulatory pressure. What has happened to the white coat effect? It must have shrunk, yes? And it must have shrunk. The reduction in the white coat effect must equal the difference between the office pressure drop and the ambulatory pressure drop. Does that make sense? Yeah. So if the office pressure drop exceeds the ambulatory pressure drop, that excess drop is the shrinkage of the white coat effect. What is a typical white coat response? So 5 millimeters, 10 millimeters, 15 millimeters, some frightening people like Mike Schachter, 20 millimeters. Well, if we have to explain this excess drop is 20 millimeters of mercury. So if we started with a white coat effect of 20 millimeters of mercury, what does it finish as? 0, correct. And if it was 15, minus 5. And if it was 10, minus 10. And if it was 5, minus 15. So these patients are slumping downwards in blood pressure as they walk in. They might actually faint when they walk into your clinic. Quite shocking. Where are the case reports of this happening after denervation, of people having reversed white coat response? I don't see them. In fact, what was the baseline white coat effect, or ambulatory minus office difference in Simplicity 1? Does anyone know? No one noticed that bit is blank in the Lancet. You go and look for the baseline ambulatory pressure in Simplicity 1. It has been deleted or is missing mysteriously. How can they not measure the... Because they know the ambulatory pressure drop. I know. There we go. A baseline denier there claims that they didn't measure the baseline ambulatory pressure. Right. So, ask yourself, and ask him during the break, how did they know what the ambulatory pressure drop was if they never measured it? Here is Enlighten. Baseline ambulatory in the press release, not shown. Simplicity 2. Baseline ambulatory, not shown. So it remains a mystery. What happens to the starting white coat effect? What does it start at and what does it end at? So what we need is trials that are controlled, randomized, and blinded before the NHS invests massive money in it. And I'm a believer in this. Many of you know that we're doing a heart failure renal denervation trial, and we showed that there was a 27 millimeter increase in walk distance, and all patients said they were better, blah, blah, blah. Did we say that everyone should go out and have renal denervation for heart failure? This is what we said. Randomized, blinded, sham-controlled clinical trials are required because that's the only way to settle questions like this. And you know this because in the drug world, you've been doing this for a very long time. So when I wanted to explore this further, I asked the editor of cardiologytrials.org, James Howard, who's actually a young investigator finalist this year, to look at all the drug trials and answer the question, how much bigger is the office drop than the ambulatory drop in drug trials? Is it 1-to-1, 2-to-1, or 3-to-1, like the denervation apologists want us to believe? And there are three types of trial design. There's one where you just give tablets and you measure pre-post. Here's an example patient. The difficulty is you enroll them on their highest day and you make the final measurement. You tell us that you cheat. Then if you have, and the result of that is you can get a 10 millimeter drop from each bit. The second type of trial design would be having a control arm, which is a major innovation. Of course, it will be unblinded because this is, in renal denervation, it's always unblinded. And so you get both the picking the highest day to get in and measuring the lowest value afterwards. But you do, the first effect is present on both. And so you get a less of an exaggeration. The ideal would be to have a blinded control so that you may cheat in the active arm, but you'll be forced to cheat the same amount in the control arm so that the difference is a reliable measurement of the estimate. And in the case of primulation, it doesn't work at all. So this result will be shown at 11 a.m. in the Young Investigator finalist presentation. Sorry, I'm just running out of batteries. Okay.
Running out of time.
Oh yeah, it's okay. This is just very last bit. So there are various ways you can measure the effect size of renal denervation. You can do it by comparing the active arm versus the failed arm. You can do it, and if you do that, you get a 54 millimeter difference. Or you can do it comparing denervation pre and post procedure. And if you do that, what you see is a 20 to 30 millimeter drop in the office, but only a 6 to 15 millimeter drop, averaging around 10 to 13 millimeters in the ambulatory recordings. Or you can do an open control and you see the same pattern. What we really need is blinded controls, and these trials aren't available. But if you look at this, what you see is as the trial design gets better, there's a drop in the office effect, while the ambulatory effect remains about the same. So I'm going to predict for you, and I'm happy if Mark will bet against me, but the effect size seen in Simplicity 3 will be down here, because I think it's more likely that the office ones are wrong than the ambulatory ones are wrong. One final spine-chilling thing. These ones marked in grey are ambulatory pressures measured without office pressures measured in the same trial. Do you ever do that? Do you ever measure ambulatory pressure only and not office? Because there were 3 such studies. They got higher drops than the ones that did it in the normal way. And I invite you to suggest 2 reasons why, if you don't measure office pressure, the ambulatory pressures are larger. Any offers? One suggestion is the brachiopontine dropo-reducinal reflex of Francis, or they have accidentally mislabeled their office blood pressure as ambulatory, and that's why they're so large. That's a very strange thing. I'm sorry, I just had to make some last-minute changes. After speaking to our legal advisors, we were able to show you this study, which gives you some insight. Here is a study which did only ambulatory blood pressure monitoring, no office pressure monitoring. And so ABPM, and showed the effect. Here was the effect. Each patient is given there, pre and post, their values. Any comments? I know we're short of time, but just anyone see anything unusual, surprising? Yeah. What are the chances of a single machine value being a multiple of 5? 1 in 5? Yeah? 1/5? What are the chances of 20 values being multiples of 5? Well, 1/5 to the power 20, which is that. Now, I don't know if this is solid evidence that they have accidentally mislabeled their ambulatory office measures as ambulatory, but they certainly meet statistically significant criteria in most journals. So really, just to close off, we are a species of optimists, and we have shown that we use that optimism in clinical practice. This optimism may be the reason why we get a massively different office blood pressure drop than ambulatory pressure drop. But that doesn't mean the office is right and the ambulatory is wrong. If we look at only office drops, we may grossly underpower our endpoint studies. and we have this mysterious, unexplained relationship between the study design and the effect size. There are very strange things going on in a few studies with large ambulatory effects. There may be some more wisdom to learn from drug trial data to find out if really office drops and ambulatory drops are different. More information will come to you in a Young Investigator Finalist Award, which is being published this week in Heart. And I've arranged with our corporate sponsor, St. Jude, for them to name their trial in a way that helps me, and especially Mark, remember the size of the effect of renal denervation. They've renamed their whole program and renamed their catheter so that every time you use it, you remember the effect size. Can you all say after me? N, lig, 10.
Thank you very much, Darrel. Now, I don't think we can allow him to get away with at least a word. So would you like to sit down here? And I'll call up Mark, and then you can perhaps take a few questions and then maybe